the male. Let's start with the testes down here. The outermost covering of the testicles called the tunica albuginea. I mentioned that before. In the front here is what's the tunica in the front of the testes? Vaginalis, right. So the seminal vesicles send their sperm towards the head of the epididymis here, through the body, through the tail, and that's where they encounter the vas deferens. So from the top down, head, body, tail. The epididymis is posteriorly, is on the posterior side. When you go palpating testicles, you can feel the epididymis quite easily. It's not a mass when you feel the head of the epididymis. You guys need to start feeling some testicles so you understand what normal looks like, okay? Larry will give out his cell number. Start traveling through sorry. Cooley, let me have your cell number.
Kool-Aid's married. He's married.
I don't care. Let's ask her. Get her on the phone. All right, so through the deep ring, out the superficial ring, through the superficial ring, back through the deep ring, internally, and around to get to the prostate gland. Here's the prostate gland right here. Prostate gland is about the size of a walnut, a little bigger than a walnut. There's the prostate gland. It sits below the bladder. You'll see that the urethra exits the bladder and goes through the prostate gland. It's joined there by the ejaculatory duct, which is when the vas deferens picks up the duct of the seminal vesicle. I'll show it to you in another picture. The seminal vesicle plus the vas deferens equals the ejaculatory duct. You got one on each side going into the prostate gland. You define the urethra here in a male as either the prostatic urethra, the spongy urethra is the part that's out in the penis. You remember I was talking about you've got that pelvic diaphragm and a urogenital diaphragm that sits below it? In the male, you see the urogenital diaphragm right there. So the prostate gland sits on top of the urogenital diaphragm. Now the part of the urethra that goes through the UG diaphragm is called the membranous urethra. So the urethra has three parts: prostatic, membranous, and spongy. Here's something else I want you to appreciate in this slide, is that the bladder extends above the top of the pubic symphysis. The bladder extends above the top of the pubic symphysis. So stab wounds, gunshot wounds above the pubic symphysis, especially a person with a full bladder, run the risk of puncturing the bladder. Same with the female.
Did you say ran through the membranous urethra? Did you say
The membranous urethra is the part of the urethra that goes through the UG diaphragm. So prostatic, membranous, spongy. While I have this slide up here, you can see that in deceleration injuries, it's possible to rip apart the urogenital system above the UG diaphragm. You can actually tear the prostate and the bladder off of the UG diaphragm in deceleration injuries. If you ever wind up dealing with blood coming from the urethral meatus opening here, do never try to catheterize that patient. If blood is in the urethral meatus, do not try to put a catheter in that patient. You need to call a urologist. What they'll do is squirt a little contrast material in here, take an x-ray to make sure it doesn't extravasate out into the tissues. One other thing I want to show you on this illustration. You see right here, there's the spongy urethra. You see it makes a 90-degree turn to go into the, so this is what you do. That's the head down there, and this is the patient's penis right here. And you're going to put a catheter in that penis. What you do, you have sterile gloves on, and you prep the area. You hold up the penis, and you take your Foley, and you start pushing it down the urethra. Looking at who? Goldfish. When it gets to right here, this is where you'll get the 90-degree bend. Right? So when, in a female, it's real easy because the urethra is only that long and you're in the bladder. You know, you can just like a dart. But a guy, you'll push it in and then you'll hit the bottom. Realize that that bottom is right here. So the easiest way to get that around that 90-degree bend is to pull up on the penis as hard as you, well, as hard as you can, but pull up firmly, and that will straighten that angle, and then it goes in much easier. Okay? So always remember that. Pull up on the penis. Funniest thing in the world ever, one of the funniest things I ever heard happen. One of the former faculty members when I was over the other program,
Oh, gosh.
she was going to catheterize this guy down at the clinic, and what she did was she had the catheter tip and the penis is lying there. What she tried to do was like, she kept trying to catch up to the end of the penis and it kept moving away. Can you see what I'm saying? Like it's a snake. She's trying to get this thing down the snake.
She did it.
She's no shark. So the thing to remember is to pull up on the penis. You got to do it firmly, not just slightly. You got to pull it up pretty hard.
I have a question. So I saw someone put a cath and like, oh boy. How do you know where the opening is on the head of the penis? Like it looked like I couldn't see. Oh, it looked like they just stabbed the thing straight through the head of the penis.
No, if the opening is kind of a slit, it's not a hole, it's a slit. So the easiest way to find an opening is to push down on the sides, and that opens the slit up. So, but you're actually right. I mean, especially in boys, you don't know if they have epispadias or hypospadias, meaning the opening can be anywhere from on the dorsal surface of the penis to the bottom. This is called epispadias, hypospadias. It's a common urologic condition. So you got to find the opening. Now, females, we talked earlier about the urethra as being in front of the vaginal opening. And you need to go find your own, you need to go look for a urethral opening. And you guys, that's where it's located. The urethra is between the vagina and the pubic bone. It's not behind it, right? But in some women, because of, remember I said the UG system, the actual opening of the urethra can be along the anterior vaginal wall. So you go and you spread the labia, there's the vagina, you're looking for the urethra, no urethra. Well, where to go to look for it embryologically, because of how the cloaca divided off, is along anterior vaginal wall. So what you have to do is put the Foley on your finger, curve your finger, and run it along the vagina until it goes into the hole. It's awfully embarrassing not to be able to find the urethra, especially when you have a PhD in anatomy.
Will we learn how to do this? Like,
Oh, you're gonna do it. Yeah, go each other.
oh,
No, they're all.
All right, everybody, listen to our stuff.
That's where you'll learn.
Bad moment. Put your
Well, they're getting 36 times. My God.
All right.
Just asking. I was school today. I was allowed.
All right, so also, note that the prostate here is anchored to the back of the pubic. Yanker is a type of suction device. Right? So, not that you would use it down here. This thing is called tuboprostatic ligament. Tuboprostatic ligament. Only guys have this. All right, if we look at if we're standing on the sacral promontory looking anteriorly, this is the picture that you're going to get. What is the name of that midline structure? The urachus. What's beside it? The obliterated umbilical arteries. What's beside that? Inferior epigastrus. Here is our vas deferens coming around, I can see it right there. Note its relationship to the ureter. Right here and over here. Now in this illustration here, we've got, this is the normal here. In this illustration, that testicle did not descend. This would be very highly unusual. I don't think I've ever seen that in my life, that there was an abdominal testicle. A lot of them in the canal, but never an abdominal. And that's how, because it goes that way, because it's getting out towards the deep ring, that's why it becomes anterior to the ureter. Okay? That's why it's anterior to. This is the, from the back. Here's the formation of the ejaculatory duct. You got the vas deferens coming in from lateral. The seminal vesicles are located lateral to the ampulla of the ejaculatory duct. These two ducts together form the ejaculatory duct. And you've got one on each side. We're going to talk about, I think it's next week, different types of cellular problems. One of them is hypertrophy and hyperplasia. The prostate has a tendency to become hyperplastic as you get older. It starts enlarging. It's benign. It's not a tumor. It just grows. You can appreciate that if this thing is going to grow, how much pressure it can put on the bladder outlet. Bladder outlet obstruction is one big symptom of benign prostatic hypertrophy, BPH. Benign prostatic hypertrophy. Also characterized by outlet obstruction is patients, men, will report a decrease in the diameter and in the force of their stream. The P stream is thinner, and instead of being able to hit the wall from here, it just kind of trickles. Okay? The other thing is difficulty getting the flow of urine started. So ask your grandpa, when he goes to the urinal, how long it takes him, how long he has to stand there before he actually starts peeing. Okay? Nocturia is another sign. How many times does your grandpa have to get up during the night to go pee? These are all signs of BPH. There are also signs of prostate cancer, so you have to distinguish between the two by your physical exam and by laboratory exam. You get all those? There are different medicines that, if it's just BPH, you can take that will reduce the pressure on the urethra here so that the symptoms will be lessened. You can also, of course, remove the prostate, which is, it used to be done quite frequently for BPH, but now it's not done so much because removing the prostate typically would damage the nerves and you wind up with an inability to have an erection. Also, if you go and remove the prostate, you remove the valves here so that you have a problem with what's called retrograde ejaculation. Instead of the ejaculate coming out, it goes up into the bladder. Okay. Here is a better picture of the seminal vesicle and formation of the ejaculatory ducts as they open into the backside of the prostate. Now, in the lab, you got to really go digging to find these seminal vesicles. They're way down in there into the back. So for you two groups with the males, clear it out as best you can and get down in there. Now, the vessels of the pelvis are such. You've got the common iliac that branches into the external iliac and the internal iliac. The external iliac goes to supply the lower extremity and the lower abdominal wall. The internal iliac supplies all of your pelvic viscera and your genitalia. Now, people get really hung up on, is this or is this that? We're not going to do that in here. We're going to, what we're going to do is on one side where you look like you can get the best exposure, I want you to remove the psoas major. Take a chunk of the psoas major out and then peel down the parietal peritoneum and follow the internal iliac down. All right? And I just want you to expose the vessels of the pelvis. Understand that there are superior and inferior gluteals that go to that are going to come out the greater sciatic foramen to supply the gluteal region. You've got the pudendal, internal pudendal. Maybe I had that backwards. The pudendal is the nerve, the internal pudendal is the artery. It doesn't really matter to me. Just say pudendal. The pudendals are going to go out the greater and in through the lesser, and we're going to pick them up tomorrow in the external genitalia. And then you have branches going to the rectum and to the vesicle, to the bladder, which is the vesicular, to the uterus and to the vagina. All right? I don't really care that you identify all of these, because tomorrow, when we do the gluteal region, you're going to see the superior and inferior gluteal quite well. There's no doubt about it. You see them on the back side. On the front side, if you can follow them to the bladder, they're vesicular. I don't care if they're superior or inferior vesicular, they're vesicular. The one that's kind of interesting, though, is if you follow this on out, right here, that one right there, I'm not sure it says it on here, is the obliterated umbilical artery. That will be continuous onto the posterior abdominal wall. So when we're talking about the umbilical arteries coming off of the internal iliac, that's where they are right there. I'll show them to you today if you have a hard time finding them. They're pretty easy to find if you know where to look. And this is what it kind of looks like here. Once you clean everything out, you're going to see the nerve roots. They're very large. You'll see these branches. Superior gluteal goes out through here, usually between L5 and S1. Inferior gluteal is down a little lower. Pudendal is way down. Here you've got vesicular branches. There's the obliterated umbilical artery right there. One of them that's easy to find, though, is the obturator. obturator artery goes out through the obturator membrane. Remember I kept saying there was an opening in the top of that membrane? That's where the obturator artery and nerves will go. I'll find that for you. It's quite obvious. That's it. That should be it right there. Okay. The lymphatics here are important. The labia, majora, minora, and the scrotum drain into the inguinal nodes. The testes and the internal parts of the female drain to the iliac nodes. So ovarian cancer or testicular cancer, you're not going to know, they're not going to come in and say, I've got these swollen nodes. It's only in skin cancers related to the scrotum or labia where you'll have involvement with the inguinal nodes that you can actually palpate. Right. Any questions? All right, let's go to